Dr. Bang is a senior intervention cardiologist, Lilavati Hospital and Research Center, Mumbai. He is a professor and head Grant Medical College and Sir J.J. Hospitals of Mumbai from 1985 to 2050. He is founding president, Cardiovascular Academic Research Foundation, and running founding course director, Indian ACT conferences. He is founding director and moderator, International Cardiology CME. And he has so many publications and book chapter in his credit. He is an excellent clinician, intervention cardiologist, great researcher, and a great orator. May I request Professor Bang to please honor us to give the prestigious late Dr. A.K. Thakur Memorial Oration. Thank you, sir.
Thank you very much for these kind words. I am pleased and honored to be here to deliver this oration, this prestigious oration, Dr. A.K. Thakur Oration. May I have my slides? Okay. Yeah, sure. So friends, we have a very interesting topic, secondary prevention. Secondary prevention, we know, is more challenging. Yeah. PPT was a idea. Huh? I have given it in the morning. So we know that the secondary prevention is more challenging than the primary prevention, because here patient is already in ASCVD risk of high risk category. They already have existing coronary artery disease. Either they have undergone intervention or they are on medical treatment or both. So these patients require particular attention because second event is a serious issue that we must keep in mind. So that's how secondary prevention becomes a primary goal for all of us, particularly for those youngsters who are taking deep interest in intervention, coronary intervention. They should be knowing more about secondary prevention. They're very, very important if you know intervention, but first you should learn how to do secondary prevention. That is a must. Okay, I will change the slide. Okay. So what is the goal? Goal is give a guideline-directed therapy to prevent morbidity, mortality, and improve quality of life and well-being of a person for secondary prevention of ASCVD. Now there are pharmacological intervention and non-pharmacological intervention and specific preventive strategies. All these are extremely important. Today, in the limitation of time, I would cover only pharmacological intervention, and the risk of the secondary prevention is more risky, more challenging than primary prevention, the reason being the residual cardiovascular risk. One is inflammation. Clinically, we all recognize inflammation with level of HSCRP. And accordingly, we have to target our treatment. That is a very important aspect. Second is a residual metabolic risk, increase in LPA, increase in triglycerides, and diabetic or pre-diabetic patients. They pose real challenge of residual metabolic risk. And third is thrombotic risk, which is we have to balance ischemic and bleeding risk in appropriate way. Apart from these antithrombotic and antilipid treatment, we also have several other goals of secondary prevention, that is S inhibitor for LV remodeling, and also the beta blocker therapy, which prolongs the life, particularly after post-myocardial infarction. So what problem we have in India is this peculiar type of dyslipidemia, which is increase in triglyceride, reduced HDL, and normal LDL-C. LDL-C, though looking normal, but it is predominantly small, dense LDL, which is highly atherogenic, and reason being insulin resistance. Insulin resistance activates the CATP pathway and converts large LDL into small, dense LDL, which is highly atherogenic. It's not only LDL. We have to look at non-HDL-C entire gamut. Unless we control non-HDL-C equally, so we have two goals. Goal is target the LDL therapy at the LDL level to get it in the level where it can prevent secondary events, and also target non-HDL cholesterol. That is very important. What is non-HDL cholesterol? It is also called as ApoB. ApoB and non-HDL cholesterol, they are identical, alternately used terms. So what it includes? It includes ApoB or non-HDL cholesterol, includes LDL, LPA, IDL, VLDL, and chylomicrons. So why it is important to know that non-HDL cholesterol is equally important to target? Because if you don't target it, once the non-HDL cholesterol crosses 130, the hazard ratio increases, which is reflected over 30 years of follow-up, that it increases slowly the risk of coronary artery disease more and more as the non-HDL cholesterol level rises. So treatment goals have been identified by various research that this very high risk patient, how do we target it? LDL-C less than 50 and non-HDL-C less than 80. This is a very, very important aspect. Unless we achieve this goal on our patient who have already coronary artery disease, and we don't achieve this, the secondary prevention can never be achieved. Lipid Association of India has added another category because in India, the premature coronary artery disease is extensively known. And South Asians, India is a part of it, the risk of coronary artery disease is very high. So category B, that means LDL-C level less than 30, not less than 50, target it to less than 30. Now, of course, the new research has come out that the lowering cholesterol doesn't harm. So lower it as much as possible, lower the better. Now coming to HDL cholesterol, we know low HDL cholesterol is independent risk factor. But high HDL cholesterol, we thought it is protective, but not above the level of 60. Above the level of 60, it is not protective at all. It can cause infectious disease, autoimmune disease, lung disease, cancer, type 2 diabetes mellitus, and kidney disease. How do we treat? Same statin we need to use and control it. So statin is our foundational therapy for secondary prevention in terms of lipid lowering. And how do we use? How does it act? It acts through inhibiting HMG-CoA reductase. By acting there, it reduces LDL-C and thereby delipidates the plaque, which converts the vulnerable plaque into a stable plaque. And that is the reason that we need to use. And various investigations, follow-up investigation, non-invasive investigation, like MRI, SPECT scan, have shown that hot plaques can be converted to a non-hot plaques or stable plaque after giving statin therapy. So what it causes after it converts from the high lipid content plaque, it becomes calcified plaque with statin therapy. And statin are not only control LDL-C, but it has a pleiotropic effect. We all know that the improvement in endothelial function, reduce inflammatory response, stabilization of atherosclerotic plaque, reduce thrombogenic response, and inhibit vascular smooth muscle cell proliferation, and inhibit cardiac myopathy. See, particularly when we use lipid lowering agent like statin post PCI, post intervention, we need to reduce smooth muscle cell proliferation. And that is where statin role or secondary prevention role is very important. Another very important aspect which I would like to emphasize is it reduces the thrombogenicity. So suppose a patient having a statin therapy going on and he develops MI, he will do fair or better than person who is not on statin therapy. And this, it stabilizes the plaque, vulnerable plaque, and Oskop's trial has shown a legacy effect. When statin continued more than 20 years, it reduces the chance of secondary event highly. And Braunwald had said that if you maintain your LDL-C level less than 70 after the age of 20 years, you can live up to 100 years without developing coronary artery disease. So it stabilizes the plaque, universally accepted statin therapy. Statin therapy reverses the plaque. It is clearly shown by a reversal trial that it does reduce plaque burden. And it shrinks the plaque as suggested by GLOGAV trial when it was compared with statin versus statin plus evolocumab. But can it disappear the plaque? We are not sure about that. So statin has multiple roles. How do we get the best benefit of statin therapy? We get a best benefit of statin therapy only when we continue for a long term. More than 2.5 years, at least minimum, or longer. Longer you continue, you get a sustained benefit of cumulative event-free survival with coronary artery disease. So outcome trials have revealed that it reduces the MACE by 50% over a period of 3 to 5 years. It reduces the mortality both in men and women, and whether you have low LDL or normal LDL doesn't matter, high LDL-C doesn't matter. You need to give statin to all these patients who have CAD, irrespective of whether they have high cholesterol or no high cholesterol. And this is an important aspect. It is inexpensive and very safe to consider. Now we have another drug which has come up in secondary prevention very well, bempedoic acid. It has a more or less similar profile as that of statin. And advantage is if statin alone cannot control the desired goal of LDL-C, we can add bempedoic acid in combination with statin. And it does reduce more 15% of LDL-C. Second, most important thing, if patient is statin intolerant, we can use bempedoic acid. Along with ezetimibe, it controls 35% LDL-C. It also reduces hsCRP like statin, also reduces hsCRP, which is an important inflammatory marker. And we all know that unless we control inflammation, we cannot have achieved secondary prevention in any way. So a patient is not controlled. To achieve the target, we need to give sometime a triple oral combination therapy, bempedoic acid, ezetimibe, and atorvastatin. This combination gives 90% patient will achieve LDL-C level of less than 70, and 58% patient achieve LDL-C level of less than 55. And overall LDL-C reduction is 63%. It's a cheaper combination compared to using the PCSK9 IV therapy, which is cumbersome. So statin intolerance, 9%, but in clinical practice, we don't see 9% intolerance, at least not in my practice. What I have noticed that those patients who complain of myalgia, we must check vitamin D level. If you correct the vitamin D level, the myalgia will disappear. So it is not a statin intolerance. It is in a patient who's got deficiency of vitamin D along with the CAD. Second thing is hypothyroid. If patient has a hypothyroid, if complains of myalgia, check for thyroid and vitamin D level. If hypothyroid is there, correct it, and the myalgia disappears. So this is very important that we need to check. So statin intolerance, never discontinue the statin immediately, never. Change the form of the statin, lower the dose, and give alternate dose. I will tell you something very important about the alternate day dose. It's the same effect that daily dose gives. Same, no difference at all. Science has proven that, and it is reported in the literature. Now, if you discontinue statin all of a sudden for any reason, then you have a chance of developing the rebound effect and more secondary events. So never stop statin suddenly. Slowly change the form of the statin, reduce the dose, make it alternate day, never stop it suddenly unless it is absolutely mandatory to do it. So then no statin and statin, if you see, no statin also has higher secondary events. So statin is a must. All patients who have a known case of ACAD, statin is a must for them. So if statin, the safest statin to avoid intolerance is pitavastatin. It's available in India. If you combine pitavastatin, ezetimibe, and bemperoic acid, it's called as triple combo. It is very good, and you can avoid expensive drug like PCSK9, which many patients of ours cannot afford it. Now, statin in elderly, it's almost sure that statin in elderly should not be stopped at all because it gives both non-fatal and non-fatal cardiovascular outcome benefit. Never stop statin in elderly above the age of 81 years. Never stop it, because many people report that there is more myalgia after the age of 81, and many people, many physicians, cardiologists control or they stop the statin. It should not be done. We can reduce the dose of statin and change the form of the statin, but never stop it in elderly also. So all these trials, what they have shown in terms of secondary prevention, lower the better. Lower the better. So both for primary and secondary prevention. Statin in pregnancy, it is safe. It doesn't cause any congenital abnormality, but it can cause preterm birth and low birth weight of the baby. Another drug which is remarkably important is icosapent. It is available in India as Cosatil, and it is very, very good. All the trials have shown that it is very good for reducing triglyceride, which is typically seen in our Indian patient, the increase in triglyceride level. And you can see the difference with icosapent, the difference, you can see the graph separating, and p-value is highly significant. So icosapent, don't forget it. It is much better and much cheaper and very good drug for reducing triglyceride in our patient, and it reduces first event by 25%, second event by 32%, and fourth event by 48%. So then PCSK9, no doubt, PCSK9, there is a controversy about whether outcome benefit is there or not there, but in acute MI, where LDL is high, we can certainly use PCSK9. It does give an outcome benefit as shown by this trial. Then this remarkable drug, inclisiran. It is a metabolic vaccine. Once in 6 months, 284 milligram, and reduces LDL-C level less than 55, and continue to reduce 2 doses for 510 days. So compliance-wise, there is nothing to beat the inclisiran. It is the best if the patient can afford. And all the 3 trials, if full data shown that Oration 9, 10, 11 trial checking the inclisiran effectiveness, and it is US FDA and CE approved for use. So first dose 284 milligram. Next dose after 3 months, 284 milligram subcut, 1.5 ml pre-filled injections are available. And then second dose after 6 months. It takes care of your LDL-C goals very well without any question of non-adherence to the drug. Then another thing is LPA. It's the most dreaded. At the moment, we don't have any effective drug to control LPA level, and it has a genetic disposition. Inclisiran does reduce, PCSK9 reduce, but niacin I use in my practice, and niacin 1 gram per day, it is not that unsafe. It doesn't cause that much of hot flushes or itching. At least I have not experienced that. There is NF kind of variety which is extremely good and very good to use. And I think we should use this. But there are now newer drugs coming. It is called as pelacarsen and olpasiran. These two new drugs are coming. Phase 3 trials are going on at the moment. And olpasiran reduces LPA by 95%. Once in 3 months, 75 milligram subcut dose of these drugs are translational. They are 100% they will be approved by US FDA, they will be approved by CE, and they will be available in market in short time. They are very safe and very effective in reducing LPA. Particularly, it will reduce premature coronary artery disease or premature coronary artery disease death in our patient. Then non-HDL goals also very important. I said less than 80 milligram. And sometimes whatever drug, oral therapy, statin, bempedoic acid, ezetimibe, we cannot control non-HDL-C. Then vupanorsen is available. It is the latest drug, and I'm sure it is US FDA approved. And it's available as a 15 milligram per kg once a month via intravenous infusion. And this drug is supposed to be highly beneficial. It has minimal side effects, but they are all very well tolerated. But as you increase the dose of vupanorsen, more and more targets are achieved very well in terms of non-HDL-C levels. Now, another drug which has come up is HLT2, another pleiotropic drug, in addition to statin in our armamentarium, and 3 trials have been done: EMPA-RAISE, CANVAS, and DECLARE trial. All these trials have suggested that secondary events are reduced over a period of significant numbers of events are reduced using HLT2, and very good drug. Most of our patients are diabetic, so use HLT2. Now they are affordable also. Another drug that is very good is glucagon-like peptide 1 receptor agonist. In combination with HLT2, it reduces all-cause mortality in patients with coronary artery disease. Extremely important to use these drugs, particularly if patient has a diabetes, and you can use even without diabetes HLT2. So all these drugs in combination we can use HLT2 and GLP-RA1, and they all give excellent secondary prevention benefit. Then, of course, if Jupiter trial has shown statin controls inflammatory marker very well, but if you have not achieved the inflammatory marker alone with the statin, you can add this new drug, colchicine, which is available and very cheap, and we can use it. Then CANTOS trial has shown that canakinumab can be used. Now, lately, there is a gene editing therapy which is trial has been started. It's called as HEART-1 trial in New Zealand, and one patient has been declared successfully being treated. Once done and done forever. That's all we need to do. Particularly good for homozygous and heterozygous familial hyperlipidemia. Now coming to antithrombotic treatment, what we have to do is before we start, if we want to reduce intracranial cerebral bleed, which is dreaded complication, if we should not have it on any patient. Therefore, we should do precise DAPT score, clinical score it is, and DAPT score to assess and balance the bleeding and ischemic risk by using various clinical parameter and this course. And we know that stable coronary artery disease, we can shorten the duration of DAPT to 6 months, and even we can reduce ultra short 1 month and short 3 to 6 months. And we can use clopidogrel in stable, but in acute coronary syndrome, we need to use either clopidogrel or ticagrelor. But the length of the therapy has to be 1 year. Various drugs, various trials have shown that antithrombotic treatment of short and ultra-short DAPT trial have been beneficial, and mono compared the ticagrelor alone in twilight trial result in complex PCI, where ischemic burden is high. And in that also it is shown to be highly beneficial, and in the multiple stents that are used up to multivessel disease, 60, the length of the stent more than 60 millimeter, and these trials have shown a particular benefit, and then when compared clopidogrel and ticagrelor meta-analysis, very clearly showed aggregated result that there is no increase in major bleeding rate if we compare clopidogrel with ticagrelor, but benefit of reducing MI is highly there. And we can see that the platelet aggregation is least with ticagrelor. Between the ticagrelor and prasugrel, ticagrelor is superior. The most revealing finding come from COMPASS trial. COMPASS trial, particularly for high ischemic burden patient, if they have atrial fibrillation, and even if they don't have atrial fibrillation, that is combination of the rivaroxaban with the aspirin. And it has shown to reduce, if you see compare the results, 24% with this combination. And rest is S inhibitor, the BP lowering medication, and lipid lowering medication. So it becomes very imperative. Many times we have this ticagrelor problem. We load the patient, but patient angiography shows that he needs to go for urgent CABG. Then we need to reverse the effect of ticagrelor, and this antidote for ticagrelor is available, though it is not available in India, but I am sure it will come in India. So evolving therapy, what it suggests that we need to look at what clinical status patient has. Stable coronary artery disease, acute coronary syndrome, or high ischemic burden. Stable, we can reduce the DAPT duration of 3 to 6 months, but for ACS, we need to keep DAPT duration of 12 months minimum. And high ischemic burden, we can think of using, as per the COMPASS trial result, rivaroxaban with aspirin. This is supposed to be very good in complex PCI and ACS and all other aspects of the secondary prevention. So in conclusion, short duration of DAPT as a routine therapy should be considered, an aspirin-free therapy, because 30% of intracranial cerebral bleed spontaneous, aspirin is supposed to be a most incriminating factor. So aspirin-free therapy is a new angle which is evolving. And for complex PCI, we follow the precise DAPT score and balance the ischemic and the bleeding risk, because we need to use DAPT for a longer duration in this subset of patients. So ticagrelor monotherapy is excellent. And guideline also says whatever I said today is based on this guideline which is proposed by ESC. Thank you very much for kind attention.
Since this is presidential oration, questions will not be taken up. And I profusely thank Professor Dr. Vijay Bang, who has come all the way from, he is our national president, he has come all the way from Mumbai. And let us give him a big hand. Thank you very much, sir, for coming here.
Thank you very much.
Thank you so much, sir, sharing your insight with us. May I now request Dr. Arvind to felicitate our eminent speaker, our eminent guest, Dr. Bang. A token of love, a beautiful gesture, this memento is presenting to our eminent guest. Ladies and gentlemen, a huge round of applause for this beautiful moment. It's an absolute honor for us to have you here, sir.